Okay, great. So basically, we're going to talk about all the technology, all the treatments that has been done to manage cancer. And as I said, because of 1 in 2 person will develop cancer in their lifetime, that is alarming. Here we have how many people in this room? 14 people, 15 people, 16 people in this room. 50% of us will have cancer in one time of our life. So it's alarming, and we really need to work on reducing that percentage from 50% into possibly 10%. If we can put it down to 1%, I'm very optimistic, that would be great. But if we just go for 40%, that is a success. So I'm not trying to be that optimistic here. And we know all the traditional cancer treatment, whether it is surgical or chemotherapy or radiotherapy or photodynamic therapy or radiofrequency ablations, they all focus on killing the cancer. And for many years, oncologists, and even when at time we are in the medical school, all our learning and teaching, it's all about how you kill the cancer by using chemotherapy, and those chemotherapy chemicals that they interfere with metabolism of the cancer, and possibly they cause increase in the free radicals, and that will induce apoptosis. Or we do photodynamic therapy, which is recently they start working on it as well, generating free radicals, and then free radicals will induce apoptosis because the apoptotic genes are redox sensitive genes. Or radiotherapy also, it's basically generating free radicals, right? And then the free radicals will induce apoptosis and kill those cancer cells. So our focus for many years treating management cancer, it's all about developing that chemotherapy that will interfere with the cancer metabolism and eventually leads to the increase of the free radicals and inducing apoptosis, or doing radio, or surgical removing the tumor. But most of the time when you remove the surgical, you still will leave some of those remnants, microscopic remnants, and you still need to have some course of chemotherapy to eliminate them. So nothing is being done on the tumor microenvironment, and that's what we are missing. Until recently, they start thinking, oh, you know what? It's not about just killing the tumor, it's also changing the tumor microenvironment and make it from a favorable environment into a hostile environment. And that's very, very important. So now we start thinking outside the box and thinking that somebody's sending message here. And so we need to figure out how we change the tumor microenvironment, not just killing the cancer, but also changing it in a way it will reject the tumor, and also modulate the immune system in the way that it will polarize the immune system into Th1 and M1 and cytotoxic T cells and kill the cancer cells. So that's what we are looking for. We're trying to modulate the immune system to become powerful enough to kill the cancer, and modulate the tumor microenvironment so it become a hostile environment for the tumor. And then also, in addition to figuring the way to kill the cancer itself and targeting those cancer. So what we are adding, yes, now recently we call them immuno-oncologists, doctors. They are very excited and happy about developing those antibodies blockades, which helps activate the immune system against the cancer. We're going to learn that. And there's many other technology. We're going to learn that today. But what is the drawback? What's the problem still with all this advance that we have in enhancing the immune system and changing the tumor microenvironment and killing the cancer? Is really the drawback is getting those chemotherapy and getting those antibodies, and getting those repurposing drugs. We can call them mitophagic or mitophagy-induced drugs like metformins and quercetrine. We learned that from the previous lecture. How we can get them into the tumor and not going everywhere. Because if you inject them nakedly, only less than 1%, maybe 0.1% or 0.01% gets into the cancer when you inject them IV. Yes, if you inject them into the tumor, that's the best way of doing it. But if you inject them into the IV, you're going to get very few percentage of those chemicals going to the cancer and the rest going to all the body. And that will lead to problems, because it will lead to suppression of the immune system, especially if you're using chemotherapy, or if you're using antibodies, it may trigger autoimmune diseases. And it may cause a problem in the immune system and disturbance in the immune system. And it will cause also the patient will not be tolerating those antibodies and chemotherapy because of the side effects due to its effect on the healthy tissue. And that's why myself and my team of doctors, Dr. Patel and Dr. Carlfield, Dr. Joseph, we're looking for a way to get those medication, to get those antibodies, to get those repurposing drugs, to get those mitochondria, mitophagy-induced drugs into the tumor using nanomedicine, but not the synthetic nanomedicine, because we got to find a lot of problems with synthetic nanomedicine. The big pharma are using synthetic nanomedicine, which is PLGA and phospholipids, but those, they're a problem because those are synthetic, and your body will start taking them. Your macrophages in your lung will start taking them away from the blood, and also macrophages in the liver. So it's not getting into the target. It's not getting the tumor. It's being hindered by those bumps, by the macrophages of the liver and the macrophages of the, they start collecting them. So if you have a brain tumor and you inject, let's say, a liposomal loaded drug, doxorubicin, we call them Doxil. The problem with the synthetic nanoparticles, which is made from phospholipids, they get also concentrated in the lung and liver, and they cause toxication in the lung and liver and the heart, and they're not getting enough into the tumor in the brain. But if we're able to hijack that by wrapping those cancer drugs, those antibodies, those repurposing drugs into a nanoparticle that's made from your own body, like platelets membrane or red blood cells membrane, then that will kind of hide them until they get to the tumor, because the tumor are very leaky, comparing to the normal tissue. And the normal tissue, they are tight, their blood vessels are tight, they don't allow those nanoparticles to go in, while the tumor are leaky, so they allow the tumor, those nanomedicine or those platelets nanoparticles pass through those pores or those leakage of the blood vessels of the cancer. And we're taking that advantage of knowing that the tumor are leaky blood vessels while the healthy tissue are not. So, and that is leaky enough to allow those nanoparticles to pass, which is around 100 nanometer, while the 100 nanometer of nanoparticles will not pass into the healthy tissue. That helps to get as much as your drugs and antibodies and repurposing drugs and mitochondria, mitophagy-induced drugs into the site of the tumor or site of the injury or site of pathology. And that's what we are adding to all the development that has been done in the field. It's called integrated immuno-oncology, and I think we need to call this as integrative immuno-oncology. And I see a lot of integrative oncologists. They are naturopath doctors, not MDs. I think as an MDs, we need to be taking charge of that, and we can upgrade that and add what's been discovered recently in the immune therapy as integrative immuno-oncology. I think the only doctor who is currently practicing it efficiently is Dr. Patel in this group on patients. She's using everything out there, including antibodies that's been recently discovered. And I think her work and efficacy of what she's doing is way higher than people who are just injecting antibody nakedly. Because if you inject those CTLA-4 antibodies, or if you inject those PD-L1 antibodies nakedly, it gets everywhere. And then what would happen, it will trigger autoimmune, self-destruction, and a lot of side effects. And I think that can be minimized using a platelets nanoparticle. There's a company already doing it, but they want to do it in a mass production. And yes, and they're using antibodies and loading inside the platelets, but they are using it in a mass production and stabilizing it using PLGA. But we're doing it in a smaller version, a clinical version that can be done in the clinical, and it's a personalized way with a protocol that include sonication of the platelets with the drug, and then nanofiltration, and then extrusion. And we are providing that training to every doctor who's interested to join the group of chronic disease prevention and management. And we use that not just for cancer targeting, but also we're using it for all the chronic disease out there. You can use it for neurodegenerative disease, you can use it for autoimmune diseases, name it, any chronic disease out there, and you want to target the pathology, infection, you can use it, viral infection, because those platelets, nanoparticles, they contain receptors that has a tendency to attach to the cancer cells, to the bacteria, to the viral, to the injured tissue, to the inflammasomes. So that's the beauty of using the plate. So this is something that we are adding to the equation here, and trying to combine everything that's being done in this field and create protocols that's more effective and has less side effect as much as we can. So we understand that the problem with all the surgeon chemotherapy, radiotherapy, and photodynamic therapy, radiofrequency ablations, is that it has side effects. We need to minimize those side effects. And also, we need to figure out how we manage the tumor microenvironment, not just killing the cancer. And that's where a new field is called immuno-oncology emerge. And I think it's creating a lot of advance in managing cancer. And I think we can do even better with adding nanotechnology in this field. Okay, now we know for the fact that your lymphocytes in your immune system is checking all the cells. It's like a police surveillance, that they're making sure that if any cells they turn into cancer, they go and they eliminate them, they destroy them, right? Okay, so Zoom is signing out. Okay, let me see here. All right. And so we know that your immune system is all the time checking all the cells, like the police, you know, checking your ID and all that stuff, and looking for the cells. If they look weird, if they look, you know, transformed, they attack them and destroy them. And this is what we call the immune surveillance, components of what we call the cancer immune editing. So any changing that's happening in the cells, it become weird, the immune system will detect them and will eliminate them. And so we can divide this immune surveillance process of the immune system into three phases. One is called elimination, which is any cell that's trying to become weird or act different, or it's become foreign, become cancer. Your immune system will go and eliminate. So that's the elimination. So in this phase, you will not see any cancer cells emerge. All the cancer cells that's been emerged been completely eliminated. But then there's another phase, it's called equilibrium phase, where the tumor cells is growing, and at the same time the immune system is killing, and to the point that they are equal. So you will have a tumor, but it's subclinical. It cannot be detected by all the clinical means that we're doing, even with X-rays. It's there, it's microstatic tumor, but it's local, it's not clinical. Is it significant? Yes, as a prevention, we need to really focus on shifting the equilibrium phase to elimination phase as much as we can. And that's why I am asking you, all of you, to start working together as a team as doctors to develop that cocktail. Maybe that cocktail will cost $100 per month, made from cod liver oil, spirulina, vitamin B12, polyphenols cocktail, which is ECG, quercetin, curcumin, and possibly also QQ10, and then have that cocktail and become a medical necessity that everybody has to take, especially when knowing that we have a chance of having cancer, which is 50%. I mean, that's a very high percentage. And so we can shift the equilibrium phase back to the elimination. So there is cancer there, but the cancer is not growing because the immune system is destroying as much of the cells, but you have that equilibrium where the number of the cells that are dying is not the same as the tumor that's being emerged. But what would happen if the tumor become wild and variants where the immune system cannot detect them anymore, and they escape the immune surveillance, and this is called escape phase, and that's where the tumors start growing and evading the immune system surveillance, and that's where we start having cancer detectable clinically. But we will try as much as we can not to work on that escape, because that escape requires treatments, and that's where you start doing all the IV treatments and also invasive treatments we're doing for cancer. If we can work on shifting the equilibrium to elimination, that's what my focus is, and that's the best way of really managing cancer. Is starting with prevention, not the treatment, because prevention is cost less than when we start treating it. And creating that cocktail that I talked about, maybe it will be successful to reduce that percentage from 50%, maybe 40, 30. But we need to have the studies to show that it's working. And if we have improved that group of doctors or group of medical community doctors, maybe you can say nurses, they are doing it as they're taking those cocktails, and their percentage of having cancer, it's 30% or 40%. That needs a cohort study in order to really come up with some data to prove that it's effective and it's working. But I believe it will work, and I think Dr. Mike Beamer, if he can work on creating that cocktail, that would be great. But what is the mechanism of elimination? How the immune system is detecting and eliminating those cancer cells. As we know, those cells, when they become weird and they start becoming cancer, they will have what we call it a neoantigen or immunogenic antigens on their surface. And what would happen? Your immune system will detect those foreign antigens, those cancer cells antigens, and your macrophage will eat them. And then the macrophages will start secreting all those chemicals that will activate the natural killer cells, and the natural killer cells will attack those cancer cells and destroy them, eliminate them, prevent them from growing. So that's non-specific. And then the specific one is that those macrophages will detect those weird cancer cells and eat them, process them, and then activate the Th cells, lymphocytes, and polarize the immune system to Th1 and cytotoxic T cells, and the cytotoxic T cells will attack those cancers and kill them and eliminate them. So that's the mechanism of how the immune system is generally eliminating those cancer cells from emerging and get rid from them from the beginning. And we need to keep the immune system doing that. We don't want them to shift into the equilibrium where the cancers it's growing, but subclinically, and the number of the cells that's being developed or emerge of cancers is equal to the number of the immune system or their death by the immune system. And those are subclinical tumor, and we need to move that by our cocktail of chemopreventive supplements that we are trying to create into the stage of elimination as much as we can. But what will happen is that if those tumor cells, I think most of the eliminations, they will eliminate those cancer cells with immunogenic antigens on their surface. But if we got rid from all the immunogenic antigen, those cancer cells, they start kind of mutating in the way that their antigens are not immunogenic anymore. And those are variants it's hard to get rid from because the macrophage, when they eat them and they process them, there are not enough of antigen to really activate the lymphocytes and polarize them enough to Th1 cytotoxic T cells to kill them. That's where the tumor cells are escaping the immune system. One way is by those antigens are not immunogenic enough to stimulate the immune system. The other thing is that the tumor cells also does a lot of things to escape the immune system. I'm going to learn that escape mechanism. One way is that they start expressing on their surface immune blockade proteins, and that will suppress the immune system. And so what will happen? Those cells will start dividing, proliferating, and escaping, evading the immune system. And that's where we start treating them with chemotherapy, radiotherapy, and changing the tumor microenvironment using repurposing drugs and polarizing the immune system and shifting the immune system to Th1, which we're going to learn them in the coming slides. So the mechanism of escaping, yes, it involves first mutations. And those mutations will cause, like any other cancer cells, when you mutate those essential genes, which is apoptotic genes, which you can see it here. And those apoptotic genes, they become insensitive to the free radicals that supposedly to induce that their apoptosis, like gene is BCL2. So that's one way that the tumors start surviving and not dying, and they become immortal. Why? Because their apoptotic genes are mutated and they become insensitive to the free radicals, the level of the free radicals that normally induce apoptosis. It requires higher free radicals than normal cells in order to induce those mutated apoptotic genes. And that's why we're doing chemotherapy and radiotherapy to increase the free radicals enough to induce apoptosis. They become insensitive to the free radicals that induces apoptosis to the normal cells and kill the normal cells. So they can sustain and they become immortal unless we start treating them and inducing enough free radicals to stimulate those apoptotic genes and kill those cancer cells using chemotherapy, radiofrequency ablation, what we call photodynamic therapy, and etc. The other genes that involve in making the cells divide and not stopping dividing, those are the STAT3 genes. The gain function genes. Also, they be mutated and they become insensitive to the level of the free radicals that normally it causes the cell to proliferate. They actually, it's higher. You need high redox potential to cause those tumor cells to divide and proliferate, higher than normal cells. And what does the tumor? What it does to keep the high free radicals, it causes the mitochondria to become dysfunction enough to leak free radicals that will keep the cell dividing and activating the STAT of the tumor. So the level possibly of the free radicals that cause the cells to divide and proliferate of the tumor is the same level that will cause the normal cells to die. And you don't need any more external signals because the mitochondria will be leaking enough of free radicals internally, which will activate the STAT and causing the cell tumor to divide without any need of any external stimulus. So they become independent and they proliferate with no checkpoints or with no limits. The way that we can treat those cancer cells, yes, we need to work on the mitochondria, either activate the mitochondria to concentrate a lot of free radicals and induce a mitophagy and blow them up using quercetin or NAD, or use metformin, which will cause the mitochondria to be more leakage of the free radicals enough to induce apoptosis. So that's what we call, repurposing those drugs. And this is how metformin works and quercetin QQ10 and NAD works. Now, the other option is giving polyphenols, and polyphenols will lower the sensitivity of the apoptotic genes to the free radicals generated by photodynamic or chemotherapy. So combining polyphenols and high dose, especially if it's IV, it will be better. It will increase the sensitivity of the apoptotic genes to the free radical generated by your chemo or photodynamic therapy. But polyphenols by itself, if you take it as chemopreventive, would definitely help to increase those mutated genes to sensitivity to the free radicals. So we can use it as a chemopreventive, and I can use it as an adjunct to cancer treatment as well. What are the things? How the tumor escapes the immune system or the immune surveillance of the immune system? It expresses antigen that does not have much of, it's not immunogenic. So when the macrophages eat them, they cannot really stimulate T cells because it's not that immunogenic. And how we can treat that, possibly infect those tumor cells with a virus that will make them more immunogenic make them more immunogenic. That's one way of doing it. And we're going to learn that from the coming slides of how to do that. And there's many other ways of increasing the immunogenicity of the tumor. We're going to learn that in the coming slides. The other way that the tumor can escape the immune system is expressing on their surface what we call the immune checkpoint blockades, like PD-L1. So they express on their surface proteins, and when the cytotoxic T cells is trying to destroy them, those proteins will inhibit the cytotoxic T cells and block them, and they become useless. So you have enough cytotoxic T cells, but because of the PDL that's being expressed on tumor cells, it may end up suppressing those cytotoxic T cells, so they cannot really destroy. They become inactive and destroy the tumor cells. So that's one of the way the tumor cells is escaping the immune system, by expressing on the surface proteins that inhibit those cytotoxic T cells. The other thing that the tumor can escape is by secreting suppressive cytokines, interleukin-6, interleukin-10, interleukin-4, transforming growth factor beta, and all of this will polarize the immune system. It's very important, this point that I'm going to talk about. All of those chemicals, all the cytokines, those suppressive cytokines will polarize the immune system away from Th1M1. So they will move them into M2, Th2, Reg, Threg. It would move them into M17, Th17. So away from Th1 cytotoxic T cells. And if you move the immune system and you polarize the immune system away from Th1 cytotoxic T cells, you cannot kill the cancer cells. Cancer cells need cytotoxic T cells. You cannot kill them with antibodies only. You cannot kill them with neutrophils. You really need to have those cytotoxic T cells attaching to those tumor and releasing chemicals that will cause holes in their cell membrane and blow them up. So that's the reason why we need to work on moving the immune system into Th1M1 by blocking those cytokines and by other mechanisms that helps to polarize the immune system Th1M1, using all this repurposing drugs that blocks the production of those immune suppressive cytokines. What about the immune checkpoints blockades, PD-L1, for example? Yeah, we develop antibodies that will block the PD-L1. That's a good news. But the problem with those, if you give them nakedly, they can trigger autoimmune diseases and they can cause problems. So that's the reason we need to load them inside platelet nanoparticle, as we're doing, so we can get them into the pathology. And that's what our group is doing right now. They are using a lower dose of chemotherapy, of photosensitizers, of those antibodies blockades, all those, and we're using a lower dose, maybe 10 to 20%, 30% of what's being used, and then wrap them inside the platelet nanoparticle to get them into those leaky cancer versus the healthy tissue. That minimizes the side effects. So that's what we are adding to what has been done by others in this field of medicine. That makes Dr. Patel and Dr. Joseph and all other doctors who are part of the CDP more unique, and I think their success will be better than the traditional mainstream medicine and better than the integrative doctors, or we call them integrative oncologists, who are doing just supplements in managing cancer. I think you cannot just do supplement. You really need to do everything that's out there, combine it together, and use the perfect protocol to kill the cancer. The other thing is cancer, how they work, they start secreting prostaglandin E2, and that will polarize the immune system away from Th1 and 1 to mReg and all that. As I said, this lecture is part 1. There will be part 2, and part 2, I'm going to talk about phosphatidylserine. It's another way of the immune system. Or the cancer cells, they use that phosphatidylserine as to block the immune system and to polarize the macrophages from M1 to M2 and polarize the immune system away from Th1 and 1. So we're going to study that, or we're going to learn that in the part 2 of this course. So this is the part 1. Okay, so the other thing is that how the tumor escapes is they actually secrete chemotaxis chemicals that will attract the Tregs, and that will attract all those suppressive immune cells, especially Tregs, or they will have their fibroblasts that associate with the tumor to secrete CSTCL2 and CXCL2, which are chemotaxis protein that attracts those suppressive cells, that attracts the Tregs. And then Tregs, when it gets in, it turns those macrophages into mRegs, and then it completely suppressed the immune system. It inhibit the cytotoxic T cells and block them from working. And so we need to work on looking for all those hostile environment factors, whether they are cytokines or they are immune checks protein on the cell membrane, and try to block them using antibodies or repurposing drugs, whatever you use. But we need to really work on changing the tumor microenvironments so that will become an hostile environments for the tumor. And there's many other ways that we're going to learn in the coming slides how the tumor microenvironments is being changed in favor of the cancer. One of the way is that those tumor associated fibroblasts and macrophages and tumor themselves, they start secreting VEGF, which is vascular endothelial growth factor, and those vascular endothelial growth factors, they are causing the blood vessels to become leaky but kinky. Okay, so leaky kinky is the problem with the kinking, and why? When they kink, they prevent the T lymphocytes from infiltrating the tumor, and the tumor become cold. And so that's why we add into our cocktail Avastin to block the VEGF, which is vascular endothelial growth factor, to restore the vascularity of the tumor back to normal to allow the infiltration of the T lymphocytes. The other thing is that the tumor tissue also stimulates fibrosis, and fibrosis causes also kinking and squeezing those blood vessels, preventing the cytotoxic T lymphocytes and the immune cells from infiltrating the tumor. And that's why we use some sort of antifibrotic drugs. And I like losartan or shockwave to break the fibrosis as much as you can. Platelets also, they can form around the tumor and they can insulate them from the immune system. So that's why we use antiplatelets to treat cancer, like low dose aspirin. Talking about losartan, it's very important. I think Dr. Patel agreed with me, and I think we start giving patients 5 milligrams of losartan. We like to give more, but the problem with losartan, it causes drop in the blood pressure. So if you want to give more, you want to give 12.5 or even 25, and especially most of the patients who have cancer, they're above 50 possibly. They already have cancer. If you can switch them to losartan, that would be great. And why we switch them to losartan? Because the tumor also express in their surface a lot of angiotensin 2 type 1 receptor. And angiotensin 2 type 1 receptor is signaling a cascade that leads to increased interleukin 6. And interleukin 6 will shift the immune system away from Th1M1. So that's one of the way that the tumor can escape the immune system. And adding losartan in your cocktail will help to block that process. So I will recommend everybody to be on losartan. Low dose of losartan is also an anti-aging. So 5 milligram is an anti-aging dose, and also it may help to eliminate the cancer. I think it's chemopreventive as well for cancer. So I will add that, and along with methylam blue. Methylam blue will activate the mitochondria and induce mitophagy. So I like methylam blue, or you can add what we call the CoQ10. CoQ10 is another way. Okay, so let's go ahead and move forward to another slide. Okay, so the immune therapy landscape, it's being changed, and we have both passive and active. The passive immune therapy is some from outside, you adding to the body immune therapy that will kill the cancer from outside, not stimulating your immune system to react to the cancer, but adding or putting antibodies, for example, passively, passive immunity to kill the cancer. So passive immunity, we either using antibodies, which is anti-tumor antibodies, or multi-specific antibodies, or we can make the tumor more immunogenic using oncolytic viruses that will infect those tumor cells and make them more immunogenic. Because we remember that when we talked about the tumor cells, they escape the immune system because they express on the surface antigen that's not immunogenic enough to stimulate the immune system. So if we are able to infect those cancer cells with viruses, then they become infected cancer cells, and then the immune system definitely will attack them, or those viruses will destroy them. And so there is already companies overseas that they are already developing those oncolytic viruses. I know Dr. Patel has a company who's doing that. Or you take the virus and you engineer it in a way it will attack those cancer cells. So either naturally they are having tropism to attack those cancer cells, or you engineer them to make them having the tropism to attack those cancer cells. That's a good thing. I like that method, and possibly we can do it at the clinical level if we get those viruses, especially the natural viruses from those companies, and you can just go ahead and give it to the patients. And Dr. Kevin Patel has a company who's doing that. The other way is doing cell therapies, CART. Everybody knows about the CART and T cell receptors, engineering lymphocytes or tumor infiltrating cells. We're going to study that, each one of them. We're going to talk about them. So this is the passive, and then also we have active immune system. In active immune system, we use therapeutic vaccines. And what is that? Active versus passive? As you said, passive is you're not really activating the patient's immune system to react against the cancer. You're giving immune therapy from outside to destroy the cancer. Okay, whether giving antibodies or viruses, just from outside. But in active, you're giving something that will stimulate the immune system to react to the cancer. So that's active. And active is either using vaccine, like dendritic cells vaccine. So you take the dendritic cells and you engineer them, possibly infect them with a virus that express the antigen of the tumor, and then you expand it and culture it, and then you put it back into the body, right? Or you give the patient cytokines like interleukin-2 or interferon gamma or interferon alpha to enhance your immune system. Or you use immuno-oncology therapies, which is those antibodies blockades that we're going to talk about them in the coming slides. So let's talk about the antibodies that we are using it as a passive immunity to kill the cancer. So it could be those antibodies as simple as naked antibodies, And those antibodies, they will attack the cancer, maybe stimulate apoptosis. So there will be antibodies designed to activate some receptor that will stimulate a cascade of apoptosis or stop the cell growth. So they will block the STAT or block the apoptotic genes, or antibodies that will stimulate the complements, and that would help to possibly create pores into the tumor and blow them up, or antibodies that will touch the cancer and then activate natural killer cells, right? So that's another way. So the antibodies will attach to the tumor, and then the natural killer cells will attach to the antibodies, and then natural killer cells will start secreting chemicals that will destroy the tumor. Or you take the antibody and you stick on it, you put on it, you label it with radioactive substance, and that's what's called radioimmune therapy. So that's one thing. And so this radiation will be destroying the cancer. Or you add to the tumor some toxins, attach it to the antibodies, and then attach it to the antibodies. Antibodies will attach to the cancer, and then that would deliver the toxins into the cancer. So it's kind of target therapy using antibodies, a way to getting those toxins and those drugs and those cytokines and those radioactive substance, using antibodies as a target therapy to reach a tumor. Still, there's a problem, because those antibodies, when you give it out, it goes everywhere. So yes, it will concentrate more on the tumor, but still you're getting it into the normal tissue. So I like to wrap those antibodies into the platelets nanoparticles to get as much into the tumor tissue. So adding platelets nanoparticle definitely enhance all those therapies that we're talking about by wrapping those antibodies into the platelets nanoparticle. Then we have another option, is taking virus that is already have tropism to attack those cancer cells. They already have receptors that attach to those cancer cells, and they infect them and kill them, basically. There's many adenoviruses that's been engineered to do that, especially for ovarian cancer. And it's very successful in some patients, not all patients. And so those viruses, you take them and you inject into the body, and then they will be attacking those cancer, or you engineer them. If they're not naturally able to infect those cancer cells, then you can take those viruses, engineer them in a way that they will have tropism to the cancer cells and destroy them, and then that will release all those chemicals, all those antigens that will stimulate the immune system, and the immune system will start clearing them and clean them and activate the immune system as well. Okay, the other way is having an antibodies that will bring the tumor cells with the T cells with natural killer cells, kind of antibody that helps to connect the dots, bring them all together, bringing the tumor cells into the T lymphocyte. So it's kind of target delivery using antibodies. That's what it is. The target delivering, or you are trying to connect all of this to get them together, so that the macrophage, the tumor cells will be destroyed by both the cytotoxic T cells and by the natural killer cells. So that's what it is. And those also, there will be some antibodies itself that they will activate the natural killer cells, as you see here, antibody dependent cell-mediated cytotoxicity using natural killer cells. So the antibodies will attach to the tumor cells, and then it will activate the natural killer cells as they attach to it, and that will release their chemical that will cause holes into the tumor and blow them up. So that's one way of managing tumor passively still. The other option is using chimeric antigen receptor T cells. And what is this chimeric antigen T cell? Which is, those hospitals that are making billions of dollars out of it. It's a new thing. It's not all the hospitals in the United States has it. So it's very unique. And why we need chimeric antigen receptor T cells in the beginning is that those tumor cells, some of them, they don't have, they don't really produce antigen on their surface that can be recognized by the immune cells, like cytotoxic T cells. In order to destroy a cancer cells, the cancer cells has to express their antigen into the major histocompatibility complex type 1. Some of those tumors, they don't have this plate that's being mutated. The major histocompatibility complex type 1 is mutated, so they can not present perfectly to the cytotoxic T cells. So cytotoxic is trying to get it, but it's mutated. Those plates that present the antigen of the tumor, it's being mutated, so you don't have the right fit between the cytotoxic T cells and the tumor cells. And that's because of the defect that's in the major histocompatibility complex. And that's one of the ways that the tumor evades the immune system, by doing that. So, but if I were able to take those T cells, those cytotoxic T cells, and able to engineer them, and instead of having this complex way of combining T cells, which has to go through a major histocompatibility complex, can I just take that surface extracellular part of this T cell receptor and put an antibody on it, and keep that inside, which is the signaling part of the intracellular part of the T cell receptor. And so this is kind of a hybrid between B cells and T cells. So they engineer T cell receptors in a way that outside is an antibody, but inside it's the T cell receptor. So they take the extracellular part of the T cell, they chop it, and they put antibodies, because antibodies does not require major histocompatibility complex on the tumor in order for to destroy it. And so that's what they did. So they take the T cells from the patient and they grow them, expand them, and they recognize which one is against the tumor. They sensitize it against the tumor, recognize it, isolate them, expand them, and then they engineer them using genetics to express those unique chimeric antigen receptor, which is a hybrid of antibody and T cells. They take the extra portion part of the T cells, which require the majors to come with the complex, which I don't want, and just put antibody. Antibodies will combine with anything that's foreign on the tumor. It does not require major histocompatibility complex. And I think it's working very well with leukemia, leukemic cells, because leukemic cells, they don't express a good major histocompatibility complex type 1. And they're very successful with, I think, leukemia in general. So for blood disease, for leukemia, chimeric antigen receptor, we have success there. But for solid tumor, I don't see much of success according to the publication. So basically then those chimeric T cells will combine with the tumor cells, and then it will just act the same like T cells, cytotoxic T cells, and they will activate the signaling and release the all those cytotoxins and from those T cells and blow up the tumor. The other way of doing it is, okay, well, we can keep the T cell receptor not to turn it into antibodies, but how about just engineering it to make it more effective in attaching the antigen along with major histocompatibility complex. So you have to have it. So we are engineering the T cells receptor in a way to become more potent, more effective in attaching the tumor cells. And so basically you take the T cells from the body, collect them, and then you sensitize them in the way that you isolate the one that's specific for that tumor, and then you engineer them, and you add the genes that express those specific T cell receptors, very effective in attaching the tumor cells, and then inject them into the body, and that would help to cytotoxic T cell, which is engineered ones that helps to kill the tumor cells. That's one way of doing it. Even for Th1, you can engineer the T cells to become more effective to recognize the antigen on the macrophages as well. So they engineer the T lymphocytes, whether it's cytotoxic or T cells, in a way that they are very effective in recognizing the antigens on the antigen presenting cells or on the tumor. I hope everybody is here. Can you hear me, guys? I'm just talking and no response. So is Dr. Patel is there? Everything's good?
I can hear you. Yeah.
Okay, so everything is great, right? Okay, so almost there. We're almost there. Okay, I know it's a long lecture, but I'm trying to give you everything that you need to learn about what has been done in this field, and then how we make it more effective using our integrative skills that the mainstream medicine they don't have, and add more to it, and make it and combine everything that's possible that we can do. If things that we cannot do, at least we know about it, and we can tell the patients, okay, we did everything we can do possible in the clinic, but there is other options that you can do it in the hospital, like CAR T cells has to be done in the hospital, special lab. I don't think you can do it in the clinic, but at least you have know about the option. But if there's anything that can be done, like the antibodies, yeah, you can take the antibodies, load them inside the platelets and a particle, inject them. You can have better results than what the hospitals are doing out there. If you take the chemotherapy and you load them inside nanoparticles, you can do better than the mainstream doctors and oncologists who are doing naked chemotherapy out there, or using even engineered, synthetic liposomes. So the other thing is that the other way of passive therapies as well is to take the biopsy from the tumor, which has the lymphocytes inside them, whether it's T cells or natural killer B cells, and then take those as isolated from the biopsy, those T cells, and then culture them, expand them, and then add them interleukin-2 to activate them and increase their efficacy, and then inject them back to the body. You know, it's like putting trained soldiers that they are very effective in killing cancer. So that's one way, is just to take those T sites that's been, or the tumor infiltrating lymphocyte that's in the tumor that specifically are destroying the tumor, isolate them, do biopsy, isolate them from the biopsy tissue, and then grow them, expand them, activate them with interleukin-10, and then inject them back to the body. That's another way. Can we do it clinically? Yes, I don't think it's impossible. Basically, take the biopsy, and you learn the technique of isolating those T cells from those tumor, culture it, possibly in the platelets lysosomes, or you learn the culture that they're doing it, and then inject them back if you have that resources to do it. If not, at least you learn that there is something there that can be done, and you can refer the patient to do it if they need it, if what you're doing is not working. Now, we talked about the passive immune therapy. Let's talk about the active ones, okay? And the active ones, we can start with the cytokines. Basically, the active ones, you just inject cytokines, and what's being approved by FDA is interleukin 2 and interferon alpha, I think interferon gamma as well. And basically you inject them into the body, and that helps to stimulate the immune system and to attack the cancer. But the problem is with interferon gamma, that's the problem, okay? So yes, it will help to stimulate the immune system and your Th1 and cytotoxic T cells when you add interferon gamma or interleukin-2. But the problem is it stimulates the tumor to express PD-L1, which is a blockade marker on the tumor, immune blockade marker on the tumor. So that's a problem. So yes, activating the tumor, the immune system to attack the tumor, but you're making the tumor more resistant by stimulating the expression of PD-L1 on the surface. So if you want to do this cytokine therapy, which you can do in the clinic, by the way, just add anti-PD-L1 antibodies, which is available out there, and I think Dr. Patel is doing it. So add interferon gamma with PD-L1 blockade, and you have better success than just using cytokines by itself. GM-CSF, which is the granulocyte monocyte colony stimulating factor, it may help to increase, yes, the white blood cells from the bone marrow. It helps activate the lymphocytes. What's the problem with that? It also stimulates the stem cells from the bone marrow. And that's the problem with using GM-CSF in the tumor. And when you start releasing stem cells from the bone marrow, those stem cells, when they get to the tumor, they turn into cancer. So that's where the problem that we have with GM-CSF, also with giving stem cells to the patients. If you take stem cells from the bone marrow or fat and inject them to the body, get to the tumor, those stem cells in the environment of the tumor, they become cancer. So that's why stem cells is not good for treating cancer for this reason. What about the exosomes and stem cells from the umbilical and from the embryonic? It's a sword with two edges. So in those cells, they do have some anti-tumor factor like p53, which induce apoptosis, but also it does have inside them growth factors like VGF. And so if you want to use exosome from the umbilical, then you may consider adding Avastin to it, possibly. That may help to at least neutralize the tumor growing effect of those exosome. And I think it's a valuable dose of Avastin. Avastin with umbilical exosomes, I think it's one way if you want to, but we know that the FDA, they don't like exosomes from the umbilical to be given to the patients for some reasons, because the big pharma are trying to invest money there and they want to go through the right channels. But it's up to you. You can still use platelets nanoparticle. Platelets still, it's outside the radar of the FDA, and you can load drugs and whatever you want inside the platelets nanoparticle using Avastin itself. Okay, so the other thing that we have here is therapeutic cancer vaccine. So what is the vaccine? Is basically you take the dendritic cells from the body and then you engineer them by putting them inside them viruses, infect them with the viruses that will express the tumor antigens, and you expand them and then you inject them back. So those dendritic cells are powerful enough. They are already being stimulated by the tumor antigen in vitro, and they will stimulate the lymphocytes and polarize the immune system Th1 and kill the cancer. So this is vaccine. It's not for prevention, but for treatment. The other option, which I think one of the doctors that I know in Nevada is doing it in his lab, which is taking the monocytes from the blood, or you take the white blood cells in the blood, which contain monocytes, and then you culture it, and they have the incubator for that, and you add platelets lysates as a media, and that will turn the monocytes into dendritic cells. And then you can take tumor biopsy, and then you grind the tumor with sonication, possibly break them out, but you need a very powerful sonication for that. You can use hypotonic shock as well and release the chemicals from the tumor, and then use that to sensitize the dendritic cells by mixing it together and then inject them into the body. So that's another way if you want to do in your clinic. And there's publications for using tumor biopsy as an antigen, and introducing it to the dendritic in vitro, and then make those dendritic cells out of monocytes, and then definitely inject them back to the body, and that would help to activate the immune system, polarize the immune system to Th1 and 1. Okay, and then we have those antibodies, blockades, and also antibodies agonists that will stimulate the immune system to effectively attack and destroy the cancer. We have the Keytruda, which is pembrolizumab, and ipilimumab, and which is Yervoy. All of those are antibodies blockade, the CTLA4 antibody blockade, ipilimumab, and pembrolizumab, which is PD-L1, and they help to block the PD-L1 and activate the cytotoxic T cells to kill the cancer, because the PD-L1, once it reacts with the T cells, cytotoxic T cells, they turn them off. The tumor cells, they express on their surface PD-L1, and when cytotoxic is trying to destroy it, they attach the TC receptor attached to the major histocompatibility complex of the tumor, which presenting the antigen, but also there is co-stimulator and co-inhibitor on the T cells, and those co-inhibitors, they will react with PD-L1 of the tumor and turn those cytotoxic T cells and they off and turn them, and they become inactive. So if we can block that using PD-L1 antibodies, then you can activate the cytotoxic T cells, and that will kill the tumor. The CTLA4, that's in the, you will see it inside the antigen presenting cells and the T lymphocytes. And when they are reacting together, the T lymphocytes, if they have the CTL4, they will block the T lymphocytes and turn them from becoming Th1, they become Treg or Th2, and they inactivate them. So they polarize the immune system away from Th1 if with CTLA4. So how we use antibodies that block them, and if you block that, then you can turn those naive T cells into Th1, or switch the Th2 to Th1 and polarize the immune system into Th1M1. So that's the other way is that the Tregs also, they have CTLA4 on them, and when they combine with the macrophages, they turn them into macrophages regs or M2, which will inhibit and suppress the immune system to attack the cancer. So using those antibodies, it definitely helped to activate the immune system to attack and destroy the tumor more effectively. So again, those T lymphocytes, they have TC receptors, but also they have co-stimulatory checkpoints and co-inhibitory checkpoints, right, on their sides. So you have a T cell receptor in the center, and then you have co-stimulatory, co-inhibitory. If you activate the co-stimulatory, that's good. That will turn the T cells on and polarize them to Th1 and kill the cancer cells, or they will become Th1, polarized to Th1, right? If you activate the stimulatory checkpoints. And you can use antibodies for that, by the way. Antibodies to activate, especially, for example, antibodies to activate the OX40, CD134. So we can engineer antibodies to activate it. That will enhance the immune system to attack the cancer or polarize the immune system to Th1. But if you have the other one, which is inhibitory checkpoints, then those PD-L1, for example, of the tumor, they will react with PD-1 of the cytotoxic T cells, and they will switch off the cytotoxic T cells, turn them off. So the cytotoxic T cells cannot really secrete chemicals that will blow up the tumor anymore, and those cytotoxic T cells become inactive. So, but if I have an antibodies that will block the PD-1 or block the PD-L1, then I can turn those cytotoxic T cells back to become active and destroy the tumor cells again. So that's also we have CTL4, so we have PD-1 and CTL4. CTL4, you will see it in the T lymphocytes and especially the Tregs. But if you block it, then those Tregs can turn into and become polarized into Th1, and they start destroying the cancer. But if you keep it like this, the Tregs can turn the macrophages into mRegs and activate the whole process and polarize the immune system away from Th1 and M1. So this is really the cycle of the immuno-oncology that we talked about. This is how we are destroying tumor by using chemotherapy, radiotherapy, photodynamic therapy, radiofrequency ablation. All of this will destroy the tumor and release the antigens, right? And then what will happen to those antigens? The antigen they will be taken by the macrophages, and the macrophages will present it to the T lymphocytes and activate the T lymphocytes. But in case that, for certain reason, the tumor, they start secreting chemicals that will polarize the macrophages into mRegs or polarize the T cells into Tregs, and you have too much of expression of CTL4, then that will inhibit the whole immune system. So you need to go ahead and give antibody blockades to turn those Tregs into Th1, or turn the Th2 to Th1 by using those CTL4 antibody blockades. And then those T lymphocytes, after they've been activated, they will infiltrate the tumor, And the infiltration of the tumor, as I said, can be hindered by the tumor releasing chemicals like VEGF, which vascular growth factor, turn the blood vessels into kinky, and that will prevent the lymphocytes from getting into the tumor because it's being squeezed or being kinked. And you need to normalize that using Avastin or shock waves, or even Avastin. Even losartan is another way to block the fibrosis as well, and open up those blood vessels and allowing the infiltration of the T lymphocytes. So anti-VEGF is one way of Avastin to increase the infiltration of T lymphocytes into the tumor. Also, losartan is another way of doing it. And you're making sure you have enough of T lymphocyte infiltration. So you may be injecting the body with cytokines that helps increase the number and efficacy of those lymphocytes. And then what will happen if you have problems with the tumor, that the tumors are not producing, or they are mutated and their antigen or the major histocompatibility complex is not well formed, and they cannot present to the T cells or the tumor cells, they cannot really interact with cytotoxic T cells. So you may consider engineering those T lymphocytes and have something which is called the CART T cell. That's one way to bypass that, to increase the T lymphocyte recognition of the tumor. And definitely, as I said, if the tumor starts expressing PD-L1, this will interact with the PD receptor, the co-inhibitor of the T cells, especially the cytotoxic T cells, and activate the cytotoxic T cells. So that's where you need to consider adding anti-PD-L1 in the equations. Also, that the tumor releases indole oxidase, which also polarize the immune system away from Th1 and M1. So if there's antibodies that will block that, that would be great as well. And I think we're good. And if you have any questions, are you there, guys? I don't know if you're sleeping or we're still people there.
Yes, thank you very much, Dr. Halasa. It's Cheryl. Can you go over the mechanisms that losartan does?
Serotonin?
Losartan.
Losartan, right?
Yeah.
Yeah, so the tumor do secrete, I think in part 2, I will be talking about losartan. I will be also talking about phosphatidylserine. Those are in the part 2 of the coming lecture. We're going to focus on that. But okay. Losartan, the tumor secretes a lot of, or express on their surface, the angiotensin 2 type 1 receptors, okay? Remember in the COVID, we talked about it, how this angiotensin type 1 receptor, when they've been overactive, they signal the expression of interleukin 6, and that polarizes the immune system away from M1, Th1, and they become more of Th17, M17. Do you remember that?
Yes.
That leads to neutrophilia. The tumor does the same thing. The tumor is trying to polarize the immune system away from Th1, M1. So they express this surface angiotensin 2 type 1 receptor. And when they get activated, overactivated, they signal the production of interleukin 6. What does interleukin 6? It polarizes the immune system into Th17, M17, which I don't want it because they will activate the neutrophils, and possibly they will be part of activating or switching the immunoglobulin to immunoglobulin G. But I want not antibodies to kill the cancer. I want cytotoxic T cells. And that is being compromised by the overexpression of angiotensin 2 type 1 receptors. And so if we block that using losartan, then we can help to polarize the immune system back to Th1, M1. And that's why we recommend patients to take at least 5 milligrams. And if you're hypertensive, you can switch all your medications into losartan. That's what happened when I have a patient and she's in COVID and she's hypertensive, I switched all her medication into losartan, and that prevent also fibrosis in the lung. And remember that the tumor also used fibrosis to squeeze the blood vessels to prevent the T lymphocytes from infiltrating the tumor. So this is kind of antifibrotic as well. And we know that angiotensin 2 type 1 receptor signaling is not just producing it's producing interleukin 6, and interleukin 6, it stimulates the fibrosis, right? And it stimulates the platelets activation, and it polarizes the immune system away from Th1 and M1. That do everything that we don't want in order to manage the cancer. It just suppresses the immune system, and it goes immune suppression way. It polarizes the immune system away from the right immune system that we need, which is cytotoxic T cells. And also it builds the fibrosis, which will squeeze the blood vessels. It builds the platelets activation, which will also cover the tumor and hide them and disguise them. So we need to break out that cycle by giving losartan. I think Dr. Patel agreed with me, and she's already giving it to their patients. And we have Dr. Mike Beamer is already developing, he has losartan in a dose of 5 milligrams, which is not that dose that will cause any drop in the blood pressure. It will be good if we have a study, and I think there are studies, to see patients who are hypertensive who's taking losartan and see their chance of developing cancer. Is it less from people who are taking are hypertensive taking other drugs, or normal people? So we want to see that study. I think we can find, if we go to WebMed or NIH, I think we will see publication that shows that people possibly who's using losartan has less risk of developing cancer versus the normal. All of this, I'm trying to trigger, my goal is to activate you to start thinking with me, so we can start investigating and start helping to perfect the protocol. So what I'm presenting here, just basics, and trying to stimulate you to really investigate more and add to the plate, so you can present here and verify what we learn here, or add to what we learn here, so that we can really develop a protocol that's effective and is better than what's being established already. Any questions?
I was just going to say that's fantastic, because I've been seeing more hospitals that are planning to open up new cancer programs, and what I'm seeing is future thinking, anticipating a rise in cancer cases due to everything that's happening, increases in oxidative stress, vaccines polarizing the immune system to Th17, making it more friendly for a cancer environment. And that's what we're doing. I don't see any reason why, we cannot learn this. I don't see why we cannot learn this stuff, cannot be aware, cannot educate ourselves to understand all of these mechanisms. And like you said, there is crossover between the understanding of how COVID works and how cancer works. There's a similarity, the way it's avoiding the Th1 response, which is so important. I do have a couple of questions because I have been aware of CAR T therapy for quite some time, and I was aware that our T cells can be replicated. My understanding is that CAR T therapy involves taking your own T cells and sort of training them to recognize the cancer, or I guess you would be hybridizing the ligand and the receptor that it's receptive to, if that makes any sense. My question is, do you know if, what if we just took our T cells and had them replicated into an army of billions? and just put them in the body. Now, I understand that would be sort of like shooting in the dark because they're not being trained, they're not being hybridized with the recognition receptors for the cancer cell, but it would boost up the cytotoxic T cells or the natural killer cells. I don't know which one it would be. Maybe it's both. Any thoughts on that? Just augmenting the T cells?
Yeah, that's already part of what we just learned, is to take the T cells from the tumor biopsy, which is the T lymphocyte infiltrate, isolate them, and then expand them by culture them with interleukin-2, and then inject them back. So that's one way. The CAR T cells, they take the T cells, they isolate the T cell that's sensitive to the tumor, and then they engineer their by injecting genetics that will express on them unique T cell receptor, but they are called CAR T cell receptor because they are not exactly T cell receptor. They are a hybrid of T cell receptor and antibodies. So they take the antibodies and they link it with the intracellular portion of the T cell receptor. So from outside is antibody, from inside it's still the T cell receptor portion, and then they inject them back to the body, which antibodies does not require a major histocompatibility complex in the tumor, so they can recognize any foreign antigen and just destroy that tumor. This is in case when you have tumors that they are mutated enough where they don't produce major histocompatibility complex type 1 that is necessary to present the antigen to and react with the T cell receptor. And leukemia is one of the cases. Most of the leukemias, the cells, they don't have enough of major histocompatibility complex type 1. And so they use CAR T cells for that. But the other options you can do, as I said, is doing dendritic cells vaccination by taking the white blood cells from the patient, which contain monocytes, and then culture them inside platelet lysates and incubate them. There's a doctor in Nevada who's doing it, but with a different technique, especially with producing platelet lysates. So I use sonication there. And then that will turn the monocytes into dendritic cells. And then you take the tumor biopsy, you grind it by powerful sonication. You need a very strong sonication for that. And you put those tumor lysates into the mix there to sensitize those dendritic cells and then inject them back, but to the body. So, and that's a vaccine. We call it dendritic cells vaccine. What's done in the hospital, they take the dendritic cells and they engineer them using viruses, and that will express the tumor antigens, and then they injected those dendritic cells that's being sensitized back to the body to kill the tumor by activating the lymphocytes. So there's many methods. There's things that we can do clinical. Yes, all those antibodies, all those repurposing drugs, everything that can be injectable, you can load them inside the platelets, not a part of getting into the body. Whereas there's things like CAR T cells you cannot do in the clinical because it's required sophisticated lab, talking about $1 million of lab, more than that. But if we can do the simple things that we're doing currently, low dose chemotherapy, load inside nanoparticle, all those antibodies, we can do better if we load inside nanoparticle, all those repurposing drugs, and this mitochondria or mitophagy-induced drugs. If we can load them inside platelet nanoparticles, inject them to the body, we can definitely do better than what's out there, and understanding what we're doing. We're killing the cancer. We're changing the tumor microenvironments to become a hostile microenvironment by breaking the fibrosis, by giving antiplatelets, by giving Avastin to normalize the vasculature of the tumor, and then giving all those antibodies to blockades to switch the immune system to Th1, or those repurposing drugs to switch the immune system to Th1, M1. If we just do that, that will give us another step. And more importantly, is how to prevent the elimination phase to become equilibrium phase, and equilibrium phase from becoming escape phase. And that's by having a cocktail of anti-tumor, chemopreventive supplements, cod liver oil, spirulina, B17, cocktail of polyphenols, curcumin, quercetin, ACGC, QQ10, and then if Dr. Patel want to add, or anybody wants to add, just go add it. And then we create that, and cod liver oil, when we create that, let's say it costs $100, $200, but that will save a lot of lives. I mean, think about it. You have a 50% chance as a doctor, you're going to have cancer one time of your life. Don't you want to stop that and reduce it from 50% to 40 to 30 to 20? And why it's not religiously recommended as medical essential, like taking blood medication, like hypertensive drugs, and taking diabetic drugs, that we need to take it because this is what it is, 50%, that's a lot. And then how I know my integrative therapy works, we need to have something that's measurable. Endothelial function test needs to be in each clinic. Everybody has it, have to have it, an ANS. And that tells you whether your supplement is working or not, because it has two things. It definitely helps to prevent cancer, but also it helps to slow the process of the aging and delay the initiation of the trigger of any chronic disease. Let's say if you have a risk of developing Parkinson's disease, instead of having it at age of 50, you would have it at age of 70 by those cocktail of supplements that we talked about. And then you can do more genomics and determine if you have any SNPs. And then that will make even those supplements even more medical necessity, as taking insulin and hypertensive drugs. So our thinking of medicine needs to change and become more personalized and more aggressive and more preventive. Otherwise, with years coming and with new generations, those mutated genes are increasing and the lifespan is decreasing. And we will end up with human distinction if we don't think logically here and try to at least epigenetically modify those genes. We cannot do much in changing the genetic maps, the genes itself, but we can change the gene expression, the epigenetics, as much as we can to slow the process, the progression, and delay the initiation of any of those chronic disease out there. Any questions?
So Dr. Halasa, Dr. Patel,
Yes.
so in case of dementia, how would you treat them when they have changes in their MRI and CT scan and PET scan?
Well, if you already have Alzheimer, already have dementia, part of the Alzheimer, for example, or any part of
early phase, early
phases, you still have a chance to slow the process. I'm not saying you're gonna completely stop it. You slow the process by giving all those cocktail that we talked about. They have anti-cancer effect, but also they can slow the process of degeneration disease. So cod liver oil, which contain vitamin D and vitamin A and all the essential fatty acids, those are essential because that will decrease all those free radicals. The reason why we have progression of those chronic disease because you have too much of free radicals and you have less of antioxidant capacity, and you have problems with recycling the waste and the toxins and those fibrillus and those myeloids that's being developed. And the more that you empower the antioxidant capacity of the neurons, the more you're able to scavenge and recycle all those waste. You can slow the progression of those dementia. So spirulina, vitamin B12, cod liver oil, polyphenols, methylene blue, and if you know more, just let us know so we can add in the cocktail. And then you can do genomic testing and find out if there's any SNPs in any metabolism of vitamin D or methylation, because all of this will lead to increase of the free radicals. So think about it. If you have genetic SNPs in methylation, it will lead to homocysteine high, and homocysteine is a free radical generator. And that will aggravate the whole disease. Your sex hormone needs to be normalized, as Dr. Z.D. Berger here, when she talked to the patients, he say, well, you know what? If you take off your sex hormones, then your aging process will speed up and you become older, and you die. That's how she is getting those patients really into taking those sex hormones as essential, not as luxury. And they are essential, those sex hormones, because if you're not normalizing your sex hormones, your aging process will speed up. So you're slowing the process using sex hormones. But before giving sex hormones, because if their receptors are being blocked by toxins and by free radicals, then adding sex hormones may be going to be harmful. So it's very important to detox the body, to increase sensitivity of those receptors of the sex hormone first, using all this integrative approach that you're doing, using your endothelial function test to monetize the efficacy of all the integrative therapies. And then if things did not improve, then you start giving the sex hormone and normalizing it to level. Because I see a lot of doctors, they just give sex hormone without looking at the background of the patients. And maybe he has too much of toxins where the receptors are being blocked, not because the ovary and the testis not producing sex hormones enough. And they get even more worse if you start giving that. Same like patients who are having problem with conversion of TH4 to TH3. And they start giving T3 like crazy without knowing, without solving the problem. Why there's a problem at the beginning, conversion TH1, TH3. They may be, the patient has toxins, oxidative stress, other source of free radicals that is preventing it. So when they give them T3, they become toxic and they get fatigued and they end up with a lot of complications. So as I know, Dr. Patel, you are very aware about all of this. So your protocols, I think, is touching everything and making sure that you're doing things in a very clear, with clear understanding. Are you there?
We can do the PNP and convert into the nasal spray and deliver it. There was a second article that has the insulin. You can deliver that, and that helps the dementia. So I don't know whether you have any experience or any of the other physicians, those whom you know have experience of using them. But these are some of the good molecules. We just have to deliver them correctly.
Yeah, I've had great success with the nasal spray as far as patients with brain fog, memory difficulties. That's a different case. I'll get into that one with a case study. But the nasal spray with methylene blue, the platelet-derived nanoparticles, B complex or methylcobalamin, and N-acetylcysteine, and then like a peptide, like thymosin beta or Erythropoietin Peptide. I've gotten good feedback from people who have done variations of that strategy. For one thing, they always say that their sinuses are amazing. But some of the patients that really didn't know, I may have been treating one thing and then I'm like, hey, I have some extra, I can make a nasal spray. They said, fine. Now one of them is asking me all the time, hey, I need another nasal spray. I really like that nasal spray. I know it's not scientific, but that's the feedback so far. It's not measurable, but it's been all positive so far. Very good sinuses and increase in concentration, decrease in brain fog. That's been the common result so far.
James, do you put that as a cocktail, or you are supplying as a separate molecules?
It's a cocktail. I'm
Okay.
measuring everything out. I won't get into the details.
No,
but
I understand that. What about, are you using that new peptide AR290 or 280, whatever it is?
yeah, ARA 290, or in other words, erythropoietin peptide, which
It's
modulates
not
the
exactly
microglia.
erythropoietin, right? Because erythropoietin has been declared as one of the molecule promoting cancer. So we don't want to say erythropoietin. That was one of the reason Dr. Shoemaker lost his license. So we just
Okay.
want to make sure that that name is not synonymous.
Yeah,
Yeah,
erythropoietin,
and
there's difference between erythropoietin protein, the whole protein, and erythropoietin peptides. Which are
Right. No, but I just because we don't know who's listening to this.
I understand, and I said erythropoietin really just so that
People can relate to it. Yeah.
people can relate to it. It's just a fragment. It's just the part that hits the innate repair receptor and modulates the microglia, but not the part that stimulates the bone marrow and produces red cells.
But we don't use erythropoietin, even peptides, for cancer because it will polarize the immune system to M2 and MREG. It's good for autoimmune disease, for neurodegenerative diseases, but you don't want that for cancer, by the way, because you want to polarize the immune system to the Th1, M1. So basically, erythropoietin peptide, it's not even applicable for cancer. And that's the reason about shooting in the dark versus knowing exactly what you're doing and what you're polarizing the immune system and how you work, which I think our group has better understanding with that than others.
You're right.
And that's why I've been implementing the Lymphocyte Map, because then I've been able to see more clearly. It has 13 windows into the immune system. Not only does it have Th1, Th2, but it's got the ratio of like CD4 to CD8. That tells us something. It is telling us is it that the T cells are high and the B cells are normal, or the B cells low and the T cells are normal. So that's a different sort of window to look through. It really is so valuable. And that way we're not shooting in the dark, and then we can see, because even when I treated a patient, I was shooting in the dark because I was trying to control what I perceived through the clinical history to be pain that is more centralized pain, involving the central nervous system, more like a complex pain syndrome. So I tried the ARA 290 because that crosses the blood-brain barrier, modulates the microglia in the brain and in the spinal cord, and also helps to fix the neuroplastic changes from that may have occurred. And he was using it for 2 months. So you would think that, okay, so now the T1 is going to be low and Th2 is going to be high. But because he had multiple things going on, he had celiac, autoimmune disorder, he had mercury toxicity, and a history of mold toxicity. That's why the map was so important, because there's different things happening there's almost like having different teeter-totters. Some things are pushing some things down, some things are pushing it up, some things are starting to wear out, like a CD8 count was sort of wearing out just from chronic inflammation. And so what it told me is that even though I did the ARA 290 for 2 months, he was still Th1 dominant, and his B cells were low. for which we had to then get another test to find out, okay, what pathogens specifically are we dealing with? And so that's a work in progress, and we're going to present this case. I think the lymphocyte map is crucial, but yes, exactly. These are cases where there is not a history of cancer, and there's not a high, I would say, suspicion of cancer that, you know, that was documented, that it's like, okay, let's try this for now just to control the pain until we can get more answers. So that was the story behind that.
Well, let me add something here. There is a community of peptides. I think Dr. Patel knows about them. And when I attend those meetings, none of them have been talking about polarization of the immune system, although the peptides, their function is polarization of the immune system. And they are providing protocols, which is shooting in the dark. They have no clue. And yes, that's the reason if you give erythropoietin peptides to a patient with cancer, definitely that will make the cancer more worse. And the reason, because the education is not there. I think that's the reason you and Dr. Joseph and the group here is to tell the people that we need to make sure we know the mechanism of action before giving anything to the patient, so that regulatories, when they come to your office, you can explain to them, why are we giving thymosin alpha, why are we giving thymosin beta, why are we giving erythropoietin peptides? You reason.
Hey, Dr. Halasa, it doesn't work that way. It doesn't work that way. You have to, you just have to show the article. You can tell it works against you. So you keep your mouth shut. If they come to if you have to face the regulatory agency, the number one is do not answer any question, and do not let them enter in your office, and call your lawyer. And that is the step number one, and step number two, and step number last.
Yes, I agree with you. There is some other dark side of it. Yes.
Regulatory agency is not. We can teach, we can do, and we can have the article in the patients, and patient signs that it is the experimental treatment, and this is the their right to try the last attempt, or whatever is the language that is in the Trump's last modification. So this is what we have to do, but there is no way out, and make sure that everyone who's using any of the things that you have discussed today, they have a good consent in the patient's file that shows that this is not the FDA approved treatment, number one. Number two, it may be considered investigational or experimental, and you have a permission to discontinue the treatment at any time. And number three is they can have they can continue the conventional treatment if they wish that. They can get out. So you have given them, and you are not telling them you are immunologist or cancer specialist. You are just the physician who's practitioner of the integrative medicine.
No,
Yeah,
I agree
Dr.
with you 100%.
Kapana, I really appreciate that. That helps to clear up some of the legal things. I personally, these are just my thoughts. I don't trust anything at this point. I have not seen any science out there dictating everything we're doing. We're backing up with science. The mainstream, whatever. I could go on and on. I don't trust anything anymore. Yeah. Nothing, because it's with everything that's happened, you know, now it's survival for me, for myself, and the people who are wanting my treatments. And I do it like a warrior, like a warrior. Like I don't care. I don't care. It's clear that there is no science, there is no logic behind what's going on, and who's dictating, you know, who you do this, do that. They're coming in for reasons other than you're doing far much better for the patients than the mainstream protocols.
You are absolutely right, but I think that we have to let the listeners know that there is a science behind it, but again,
No,
we are
there's a science behind what we're doing. The science behind, oh, you cannot do peptides, you cannot do stem cells, you cannot do this, you cannot do that. There's no science behind it other than politics and money. And that's just simply the case. And honestly, I'm tired of it. I'm tired of all I can do is go for the truth. But I don't trust any of the regulatories, any of the, I respect them.
you
and I know
trust
that,
them, or whether you
I
trust
know I
them
say
or you don't trust them.
I respect the individuals who are doing their jobs. Okay, but in general, what I've seen over the past 2 years, it makes no sense to me whatsoever. And I just all I can do is just study the research, read the scientific papers, use clinical judgment, and do what you said, Dr. Kalpana, and just make sure that the consents are there. But this is just nonsense. It's pure nonsense. It's all political. It's all money, and that's just how I
But
feel.
your license is at stake.
I don't care. I honestly, I don't care.
Right, let's give you an example right now. Let's say right now, everybody recognizes COVID, it's over, right? And everybody say COVID is not over. Even the news, they stopped talking about COVID. And now they still want to vaccinate kids.
That's what I'm saying. Well, I mean, that's what I'm saying. This is
Why do you want to
ridiculous.
vaccinate nobody? Nobody.
You've got Omicron.
Omicron
Omicron is perfect. It's giving herd
Omicron is a
immunity.
good
It's
thing,
it's giving a T cell response. I mean, how much more ridiculous does it have to get?
Right.
Like, really? The problem is the people on in this conference call, people who go to these kinds of things, they actually have brains.
Right.
They actually have brains to actually see the truth and not go with the nonsense that's being put out there. I mean, people are walking around with masks outside. I see people wearing masks in their car. I'm like, what are you doing? Maybe they've fallen in love with their masks and it's keeping their face warm or something. I don't know, but look, I have never come across a non-medical person who actually read a scientific paper. That's one thing I still have not come across. So whatever they're doing makes no sense to me. And number two, it's obvious. It is 100% obvious. Everything that is going on is politics and money. I don't care. I'm going to do what the science says. I'm going to follow the science. I'm going to follow what Dr. Kapana says and get the consents. But look, if somebody's got to say it, I'll say it. I'll be the one who says it. It's nonsense, and most of it is asinine, and I'm not having it anymore. I'm not dealing with it. I shut the TV off. I'm not listening to that stuff. I'm just going to go with the truth. Eating healthy, learning how to do some of this stuff, using berberine and some of the other cod liver oil stuff is really amazing. Even there was a question, by the way.
This is a question. Can you read them, Dr. Joseph, the questions in the text?
Dan Stein had asked about the lymphocyte map. It is a company called Cyrex. We had met them at the Environmental Medicine Conference in San Diego. It's amazing. So Cyrex, C-Y-R-E-X. They have a lymphocyte map, and then depending on how many out of 13 polarities you have, then there's another lab you can get that's that can pinpoint maybe what are the pathogens or are there allergies that are causing this. So and they have somebody to go over this. They've got a physician who has a lot of experience. I would say he's definitely an expert that can help to, when you get the results, to go over it with you, almost like a panel, like they have their own mastermind to go over these cases to help you decide where to go next. And so that's what it is.
What does that mean? Where to go next?
What's
So thanks for trying to answer my question. Did you say Birex with a B or Cyrex with a C?
C as in cat?
C as in cat, Cyrex. Okay, got it.
Yeah. C as in
Dr.
cat.
Giovanni, you will find Dr. Giovanni I asked him to come here and present. Hopefully we'll meet him again in A4M or we have a meeting on next month. I hope everybody will attend it because I'm going to speak there. It's the Academy of Osteopathic Doctor and Integrative Alliance. Dr. Patel is going to speak there too, I think.
Yes.
With
yes,
Dr. William Bell Cleaver. So if you want to know about the brochure and about the conference, you can text me and I'll send you that. But I think Dr. Jusuf is going to be there. Dr. Sandra is going to be there. Hopefully Dr. Cheryl. For a long time, I'd meet in person, so hopefully she will be there. And other doctors, if you want to come, just text me and I will text you the whole program. It's going to be in Flamengo next month, March. And I would like to meet you all. I don't know what topic I'm going to talk. Either it's going to be on COVID or it's going to be integrative immuno-oncology as a new field of medicine that our group is trying to establish as part of chronic disease prevention management, using platelets nanoparticle as a delivery mechanism. But we're going to meet there and we're going to have dinner and lunch as we did in, if you remember Dr. Dan in A4M. It was a good meeting, right?
Yeah, you mean in December.
Right.
Yeah.
So we're going to have that again
awesome.
in Flamingo. And you're
Sounds
welcome to attend. Just text me. You have my information. I will send you the information. I'll send you the cell phone of Dr. William Bill, and I would recommend that he will give you a special discount or whatever. I'll give you his cell phone number. He's the organizer. He's the boss. And I'm helping them all the way, of course. Dr. Bill is a friend of mine. And it's going to be very friendly meetings. And also, they have some entertainment program that Dr. Bill is doing. It's kind of acting. It's kind of a sketch of cinema that the doctors are acting some kind of a horror movie at the dinner night, and it's very entertaining.
Did real life enough of a horror movie?
Yeah, they did. They have a kind of a horror movie.
Somebody
It's kind of a story, and
Contagion?
actors there, and they're wearing all the old dresses of 1970, something like that. And I will send you some recorded video of that acting scene that they had. But he's really entertaining the doctors. I enjoy his meeting, the Dr. William Bill. It's called Integrative Alliance, which is MD mixed with NDs with DOs. But it's a very friendly, nice conference that I would like everybody to attend.
Sounds good.
Now I was going to mention something really quick with the Lymphocyte Map. They also have a list of all the different supplements, natural herbs, everything that if you need to bring the CD4 count up or down, or CD8 up, or TH1, TH2, all these different vectors. They've got a list compiled with all the data backing it up, which ones, including they had berberine on the list, different herbs that, if we can be as natural as possible, I think that's the best. I really do love peptides, but it's nice to know that, if you're recommending a supplement, you're not shooting in the dark with the supplements either. You're being precise. And the lymphocyte map is the most precise test for the immune system that I've seen so far.
Yeah, lymphocyte mapping and genomics. I mean, generally speaking, you can start with it's like somebody has infection and you give them empirical antibiotics, but you take the culture and then you do the culture sensitivity to find exactly what antibiotic that's sensitive to the bug. But you don't want to wait for that. You just give the empirical antibiotic and then you switch them to the specific antibiotics. The same thing here in integrative medicine or chronic disease prevention management. We can give them empirical supplements that will enhance the immune system and balance the immune system, and to fight the cancer or neutralize balance the immune system for any autoimmune disease or neurogen. But then lymphocyte mapping and genomics will help you to specify exactly what nutrition that the patient needs to be on and forever, and turn that nutrition to become an essential for them. Because if you have SNPs in metabolizing vitamin D, you really need to have extra vitamin D as taking blood pressure medication, and it becomes essential for that patient. Like, this is vitamin D, you have to take it like you're taking your blood pressure medication, because you do have genetic SNPs. And if you don't tell them you have genetic SNPs, then they will not be compliant to take the vitamin D, because they see it as luxury. As all other mainstream medicine doctors, they think supplements is luxury thing, and what is treating the patient is the big pharma product. And that mindset needs to be changed. Now, insulin is good. I mean, if you use it in a small dose and in a monitored way, target way, that possibly it's going to be effective. But the reality is that if you have patients on insulin, insulin causes oxidative stress. It causes the receptor of the insulin become insensitive with time. That's why they need more insulin, and more insulin causes more resistance to the insulin. It generates free radicals that turns those receptors of insulin insensitive, and that's why they start adding more and more. So if you're able, with your integrative approach, wean patients from insulin and replace them with berberine and with other hypoglycemic nutraceutical drugs, and change their lifestyle, that's management. If you wean patients from big pharma products and you're able to control the sugar, sugar is a free radical generator, by the way, which speeds all the degenerative diseases and trigger all the autoimmune diseases out there. Yes, I think that will be an accomplishment and a success if you're able to reduce the dose of insulin into 50%, or reduce the blood pressure medication into 50%. And as much as you're able to reduce and normalizing the parameters and the vital signs of the body, and the metabolics, using nutritional, because they are more friendly to the mitochondria. What I'm trying to say is that patients taking a statin, for example. Well, statin is good. Yes, it's a nitric oxide donor, but with time, it interferes with mitochondria and it generates free radicals. And then patients, they become having problems. So it's short term is good, but all the big pharma products with long term is not good, because they interfere with mitochondria, generate free radicals, and that would trigger chronic disease and make things worse. And then you need to add more statin, more insulin, more of those big pharma products to compensate for the interference of the mitochondria damage that you have. So all big pharma products, except methylene blue, are not compliant with the mitochondria. They do interfere with the mitochondrial function. But all the natural products, berberine, all that, they are compatible with mitochondrial function. In fact, they enhance them. And that's the reason switching it from big pharma to supplement as much as you can, not suddenly, but gradually, with life's change, and monitorize your treatment using the tier function test and ANS. I think it's the best way of doing. And if you're able to reduce the big pharma dose, the narcotics, the diabetic medication, the hypertensive medications, the autoimmune steroids and antibodies into 50%, that is a success. That's management. And I like to use word management, not treatment, because the regulatories, they see word of treatment means cure. But managing, not necessarily cure. Managing is trying to control it and improve it and slow the progression of the disease and improve the quality of life of the patient. Any questions? We have new faces here that I see. Dr. Anna, Dr. Hall. If you'd like to introduce yourself, if you have any question. Arthur.
Can you stop chewing?
Yeah, you go ahead if you want to talk and present yourself. I think I did not see you before, so it's good to introduce
I'm trying to
yourself.
start my video. There we go.
Right.
Okay. My name is Hal Blattman. I'm an integrative, functional, holistic practitioner in Cincinnati on Manhattan. I got into cancer about 3 or 4 years ago with the advent of a patient coming and asking me to continue mistletoe therapy. So I've been doing mistletoe, high dose vitamin C, ozone, ultraviolet light. We've been in this for 30 years. At one point, I was the president of the American Holistic Medical Association. I'm very glad to have been invited in and to listen to this. I've learned a lot. A lot is filled in the blanks that I've missed along the way. So I'm glad to be here. So thank you very much for running and hosting.
Sure, and I would like to see you every week. And also, if you want to speak, we're looking for speakers. I don't know if Dr. Patel want to present next week, or maybe yourself, or anybody here is interested to add more to the plate. That would be great.
I'll be glad to chat with you on the side about that to see if what I know might be appropriate for the group.
Sure, please do.
So I have a question for the group. Sala, you may be our expert on mitochondrial function. For frequency stimulated microcurrents, there are reports that increase ATP production by 500%. Are you aware of any role for that in what we're talking about here?
You're talking about microcurrent, electric microcurrent?
That's correct.
Right. So electrons are antioxidants. They neutralize the free radicals. And if you neutralize the free radicals, you're increasing the glutathiones, you're increasing the NADH, and you are increasing the ATP, definitely, along with that. So I see electrical therapy in general, whether you're using it for spinal cord stimulator, whether you're using it for TENS units, whether you're using it for transcranial. Some of them, they use it for headaches. You know, grounding. It's electrotherapy as well. Those electrons, or acupuncture. Some of them, they use electricity with the acupuncture, putting those electricity into the body. So yes, they are antioxidants. They neutralize the free radicals. They reduce them, and doing that, it definitely will improve the mitochondrial function, because too much of free radicals compromise the mitochondrial function. And it will empower the antioxidant capacity of the body. I am with electrotherapy in many diseases, so 100%, yes. Did I answer the question? Okay.
Yeah, and so one thing that's puzzled me is, sort of being new to this area, where you provide actually oxygen, be it either as ozone or a chlorine-derived molecule that shall not be named. Wouldn't that presumably have the opposite effect by inducing free radicals and potentially doing harm?
Right, and that's one of my forte. I opened a nonprofit organization. It's called the Academy of Oxidative Disorder. And I was learning about this oxidative and redox and free radicals. There is pathological and there's physiological. And so oxygen and ozone is physiological free radicals. And oxygen of the ozones, their free radical potential at the normal level, at physiological level, it actually stimulates your genes to express proteins. It stimulates proliferation and differentiation. So you need that physiological free radicals. In order to understand it, when you're exercising, you're generating free radicals. That free radicals stimulate the expression of the proteins, and the proteins will increase the mass of your muscles. So the free radicals is generated by your exercise, the stress that you are producing in your body. the gravity on the Earth versus the people in the astronaut in the moon or astronaut in the space where there's no gravity, there's no stress. They end up having osteoporosis and weakness and atrophy because they don't have the physiological free radicals to stimulate the expression of the protein and strengthen the bone and muscle. That's why when they come back, they have to go through certain rehabilitations in order to strengthen their bones because they can walk on the gravity of the Earth. So physiological free radicals is good. So ozone, oxygen, their free radical level, redox potential, it's physiologically, it will stimulate the expression and differentiation, proliferation, and expression of antioxidant genes, right? So see the opposite here. It expresses the antioxidant genes, those physiological free radicals. But if you do too much of it, you may switch the whole thing into pathological. And that's the same thing if you're exercising and you do too much of exercising and you generate pathological free radicals, you end up with bone atrophy and muscle atrophy. That's why in exercise, there is watches and there's a system out there that tell you, hey, you know, you need to stop. And they use it with sympathetic tone. If they too much sympathetic tones, that means you have too much of free radicals, then they say, this is the time when you have to break a rest, because if you do more, you're actually causing atrophy of the muscle instead of building your muscles. And so we need to know the difference between that. And then the free radicals, there's hydrogen peroxides, and there's superoxide radicals, and there's oxygen. What is more clinching and extracting electrons is the superoxide radicals. And so when you give ozones, those ozones and hydrogen peroxide and those oxygen, they consider antioxidant for superoxide radicals. So they will neutralize the superoxide radicals and turn them into hydrogen peroxide or water. So ozone and oxygen, I think it's better term, it's a redox buffer. So if it's high, it brings it down. If it's low, it brings it up. It's like pH buffer on the other side of the equation when we're giving buffers.
You know, what this reminds me of a little bit is this concept of hormesis with a little bit of radiation exposure.
Right.
And it's stimulatory to DNA repair, it's DNA to growth and antioxidant pathways. Obviously, a lot of radiation is bad for you, but a modest amount of radiation is probably neutral. And if it's just a little bit of radiation, it's probably actually stimulatory and good for you.
Exactly. Same like phototherapy, they work the same way. It stimulates the release of free radicals, open up calcium channels in a moderate amount to generate those free radicals to trigger the expression of the proteins and the antioxidant enzymes. Because if you don't have that physiological free radicals, you cannot express antioxidant enzymes, which is very critical. And so you need that physiological free radicals, and you can use it with photo, you can use it with electromagnetic, you can use it with electrotherapy. They also help to generate that physiological level, a spark of the free radicals that will trigger. But too much and constant, like the 5G and all those electrical wires that those cables in Vegas, it's completely wired with electromagnetic constant exposure. And when the first time I detect my thyroid cancer was in A4M in the hotel, and I feel it. So yes, that's where we need to not to be exposed to constant and healthy electromagnetic or light or any of those electromagnetic waves. You're right.
I was just gonna bring another angle to it. It seems like everything that we're doing causes a spark. You know, you need a spark to start a car or to light a lighter. And even if you're giving, like, say if you gave platelet-rich plasma injected into the knee and there's an initial inflammatory response, well, that's not necessarily a bad thing because it's triggering the body's healing mechanism. The same thing, whether it's ozone, my understanding is that these, the free radicals or the ozonites, I guess they call them, that are, you know, that are coming off of you've got the O3, so you've got an extra oxygen free radical is it's communicating or triggering a T cell response. So it's boosting the immune system but then those T cells can also be immunomodulatory at the same time. So I'm seeing a common thread, even when we talk about red light, that one's very specific. If you do not have inflammation, the way that it's absorbed by the cytochrome of the fourth cytochrome enzyme, it's going to go in one or two directions. If you have no inflammation or oxidative stress, it's going to trigger an inflammatory response, which will trigger regeneration. But it's a burst. It's not a continuous, non-ending, non-stop oxidative stress. It's a burst of oxidative stress. If you do have oxidative stress, then it goes in the other direction and buffers the redox. That's what I've learned through this group. And so that seems to be the common thread with whether it's ozone, whether it's giving some sort of platelet-rich plasma, red light therapy, or some sort of even acoustic wave therapy triggers a burst of oxidative stress, but that's different than chronic, unrelenting oxidative stress. A burst of oxidative stress turns certain things on.
Right, and we have the cell cycle itself, and that's what one of my lectures I recorded, I think, where the cell cycle is controlled by free radicals. Let's say, and cells with their not dividing or G0, they are 240 minus millivolt. And then if you increase the free radicals and if you turn it into minus 220, then that will kickstart the proliferation and division of the cells. And then if you go to 200, the cells stop dividing. That's a quiescent phase. And then and then you have the phase of differentiation. And then if you go farther, then you will be stimulating apoptosis. Like if you go to 140, then you will stimulate apoptosis. So the cell cycle itself is controlled by the redox potential. And so you have to have enough of free radicals to stimulate the cell to proliferate, differentiate. And then if you go farther and increase the free radicals, then you will induce apoptosis and kill the cell. So you need to have that free radicals to be adjusted at physiological level where it does not cause apoptosis if you are trying to cause healing and trying to stimulate the muscle growth. But if you go beyond that, which is too much of exercising or too much exposure for constant energy, then that will generate too much of free radicals that will actually cause apoptosis and kill the cell. So the redox control of cell cycle and health and disease, there's a big publication. If you go to PubMed and you write down redox controlling cell cycle and health and disease, there's a big publication. It gives you better understanding of how all this is connected, and understanding redox and understanding the immune and metabolic. And this is the language that we are using to manage chronic diseases, those three triangle, in addition to nanotechnology to deliver the medication to cytopathology. And understanding how things work and how they're connected to each other. They're all linked together. If you adjust the immune system, you adjust the redox, and if you adjust the redox, you adjust the metabolic, and they all connect with each other. And in management, let's say if you want to manage Parkinson disease, we give them whatever they are deficient, which is L-DOPA, that's metabolic. But also you want to slow the degeneration of the dopaminergic neurons, which is due to those free radicals that they are produced by the cells itself, because those dopaminergic neurons, they have problem of recycling their waste. And L-DOPA itself, it can be metabolized and become quinones, and they become free radical generators, and they can aggravate the whole process. So that's why we use integrative approach to neutralize those free radicals, decrease those free radicals of the body, whether it's coming from leaky gut syndrome or from the toxins in the body using detox or using light therapy, using stem cells. All of this helps to decrease and buffer the redox, to slow the progression of the degeneration of the neurogenic diseases and slow the process of the Parkinson's disease. And that's the integrative medicine approach versus the mainstream medicine approach, where they are giving L-DOPA. L-DOPA is good. Metabolically, you're fixing the deficient, but L-DOPA can turn into metabolites that is free radical generator and can accelerate the process of the degeneration of the neurons. So giving L-DOPA by itself is really not the management of Parkinson's disease only. You need to give them all, empower the antioxidant and recycle of the toxins to slow the progression of the neurons. And that is using the redox medicine. In addition, you can use peptides and immune modulators to switch the immune system into M2, MREG, THREG, and that also helps to slow the attack and destruction of those neurons. And using peptides like Erythropoietin Peptide that Dr. Joseph James has very good success with it, of thymus and beta. Okay, great. So
great.
any questions? Everybody's happy here? Dr. Sandra, are you there? Okay. And Dr. Zidi, everybody's good?
Hi, thank you so much for an excellent presentation.
Great. So we'll see you next week.
Yes.
We will have some speaker, maybe Dr. Joseph or Dr. Patel. So see you next week, and good night, everybody, and Monday. Take care.
Yeah, thanks again, Dr.
Thank
Halasa.
you.
That was excellent.
Good night.
Joe.
Thank you very much.
Okay, bye.
Pleasure.